So, Assalamu alaikum.
Salam alaikum.
Today we have Dr.Mortada Jubara. So, please tell us more about yourself.
Okay, thank you for this nice meeting and welcome. I am Dr. Mortada Jubara, anesthesiologist, a specialist in regional anesthesia and pain management. My experience in anesthesia, 11 years. I'm from Iraq. I work in Iraq, also work in USA, in Chicago. I am international specialist in ultrasound guided regional anesthesia. This is a new technique, just introduced before years. Faculty member in New York School of Regional Anesthesia. And also I am a trainer of the candidate of American Board of Anesthesia in Chicago and Advocate Medical Center.
That's great.
Thank you.
What are the conditions of the patient that will make the local anesthesia obligatory for the surgery?
Well, that is a nice question. Now anesthesia different from the past years. With the introduction of the new technologies in the medicine, like the ultrasound machine, nerve stimulator, now we can give the regional anesthesia more safely to the patients who can tolerate the regional anesthesia. There is no obligatory in the medicine, but we discuss that with the patients. All the patients have interview before the surgery, this history before the surgery. So we go to the patient, we discuss to him. So now that depends to the doctor. Doctor, personality, how to convince the patient, knowledge, basic, and skill. So if I have a skill and good personality to treat my patient, to convince my patient to do both or one type of anesthesia, of course the patient will get the benefit.
What are the contraindications to give a local anesthesia?
Yeah, we have, in medicine we have two types of contraindications. We have absolute contraindication and we have relative contraindication. The absolute contraindication, the first absolute contraindication, patient refusal. It is ethically to ask the patient before any procedure, I will put this needle in your arm, for example. The patient said, no, I don't accept that. You will not do that. Ethically and medically. Just in only condition, if this needle is life-saving to the patient, you should do it. Otherwise, no. Okay? Because you know more than patient about his health and condition and the result of or complication of his disease. But in elective surgeries, for example, cesarean section, now in all the studies say the spinal anesthesia, neurological anesthesia is better to pregnant women scheduled for delivery, spinal or epidural anesthesia. Less side effects, less complication, less mortality rate. That depends to a lot of studies, thousands of cases. But some of pregnant women, when come to the hospital, they refuse to put the needle in the back. I refused, and she is elective. I can't obligate her to do spinal anesthesia. Okay, I will give you general anesthesia, but general anesthesia do from all the complication of general anesthesia, or from the drug side effect or allergy to intubation, the laryngoscope, maybe do the fractured teeth to you. This is from first step. Then maybe I put the tube because of the physiological changes during pregnancy lead to the more edema here and high pressed, and that make the intubation is difficult. So maybe failed intubation and you pass to the period of cyanosis, and the cyanosis will affect your baby. And then, okay, I will put the tube, but because of the progesterone effect, the lower esophageal sphincter is lax in the pregnant woman, and maybe that lead to because of the loss of the sphincter tone, because of the muscle relaxant, maybe lead to the aspiration, and the bag the food and enter to the trachea and the lung and do Mendelssohn syndrome, that chemical pneumonia. Then during the surgery, maybe the side effect of inhalational drugs, the maintenance of the general anesthesia lead to the arrhythmia, and then in recovery period. So I should discuss all the side effects of the general anesthesia to the patient. Most of them, when hear that, no, we need a spinal anesthesia. Because the normal person, not doctor person, haven't any idea about the anesthesia. Okay? So I should clarify everything to the patient. Should discuss that. It's like interview, pre-operative interview between me and my patient. And we have some relative contraindication. For example, I have a shocked patient. The shocked patient not candidate for the regional anesthesia. Why? Because I should resuscitate the patient first. Because if I inject a half maximum dose of local anesthetic to this patient may lead to the systemic toxicity. Because here the clearance of the drug and the reuptake of the drug and metabolism are different. Because the patient in shock state, tachycardia and hypertension. Okay? And the third absolute contraindication, infection. If I have, for example, femoral nerve block and this area is infected, lacerated, whatever cause, I can't put my needle to the infected area and take all the bacteria toward to the nerve. Okay, so the infection or abscess or cellulitis at the site of injection should be avoided. So this is absolute contraindication. And in neuroaxial anesthesia, for example, not in peripheral nerve block, if the patient take anticoagulant drugs like clopidogrel, like aspirin, for example, any medication may make the blood thin. So any prick in the back may lead to the bleeding and oozing, and without good coagulation, the blood will collect and make like hematoma, and the hematoma will compress the spinal cord, and it leads spinal hematoma, and that lead to the another surgery. So this is the absolute contraindication, and the relative contraindication. Some patients with severe heart disease, uncorrected, for example, severe heart failure, because here will pass to the systemic toxicity also. That depend to the protein and globulin and the kidney function and how to secrete the metabolite of the local anesthetic. If the patient in acute renal failure, I can give him even quarter of the dose of the regional anesthesia because the drug will circulate without excretion. Okay?
Okay, what's the latest update in the field of local anesthesia?
Yeah, now as I mentioned, this is the technology. Now the ultrasound guided regional anesthesia, this is the updated of anesthesia. Now we do by ultrasound guided everything related to anesthesia and also to pain management. So for example, I do per year at least 2,000 cases by ultrasound guided regional anesthesia with pain management. And now this is the update, give the regional anesthesia a new position. High success rate, less complication, reduce the volume of local anesthetic, because when I deposit the local anesthetic precisely around the nerve, I need less volume. Well, if I give it blindly, I should give a large volume to cover everything. But if I see everything, I can go to the border of the nerve, epineurium, and inject, for example, instead of 10 ml, 5 ml, and see the separate of local anesthetic around it. Just manipulate my needle. So this is the difference. So the updated now of the regional anesthesia is ultrasound, introduced ultrasound machine.
Do you think that regional anesthesia is needed, specialty in Middle East?
Yeah, of course. Now we are in the war in the Middle East, especially in Iraq and Syria. And during the war, shortage of staff, medications, logistic support, and low medical health services. So, scientifically, the general anesthesia need more monitoring, more staff, and more space. because the patient have loss of consciousness during the surgery and post-operative need to recover from the residual effect of the general anesthesia, like the muscle relaxing drugs, which make a respiratory failure, for example, or paralysis. So, in battlefield, for example, and the casualties of the battlefield, there are no space for the hundreds of soldiers in one conflict. So here's the role of regional anesthesia, to do the blocks for many soldiers at the same time, better than keep the soldiers in waiting list, suffering from the pain and the bleeding and complication, till wait the operative room to be evacuated and start by another patient. And even if we have a lot of operative rooms, post-operatively I need, with general anesthesia, I need staff, I need monitoring, I need intensive care unit, because maybe the patient has respiratory problem. I give him general anesthesia and the complication of the respiration increased, and then the patient needs respiratory care unit. I haven't, for example, space to put the patient on ventilator, intensive care unit ventilation, and I need at least 5 staff, nursing staff, for 3 to 2 shifts. Okay, substitutions or sequence. So this is possible in our countries at time being. So in the Middle East, the regional anesthesia, because of the also economically, the cost effective of the regional anesthesia enhanced to develop the regional anesthesia in the Middle East, because the cost of the needle and the local anesthetic is a quarter of the cost of the general anesthesia per case. So the drug related to general anesthesia more expensive, the monitoring more expensive, also the personnel and the staffs we need more, so the cost or the payment for the general anesthesia is more higher than regional anesthesia. So economically is the best, depend to our conditions in our countries in the Middle East, the war against the terror, the war against the different political issues. We need to enhance the regional anesthesia here in Middle East more than other countries or other areas in the world.
What's unique about being an anesthesiologist?
Oh, well, it's a big question. I can't answer it in minutes, but anesthesiologist now is like a joint of the medicine. So suppose in hospital, you are in teaching hospital, you have 100 surgeons, different specialties, orthopedicians, neurosurgeon, general surgeon, obstetrician, gynecologist, whatever type or specialties. And this hospital haven't any anesthesiologists. What they can do? Nothing, right? Nothing, just simple wound suturing. Otherwise, they come back to the before 200 years when anesthesize the patient by. Okay, so now anesthesia is the updated of the medicine, and it is the new field that contain it's like multidisciplinaries. You can work in intensive care unit, you can work in respiratory care unit, you can work in pain management clinic, you can work in operative room. Anesthesia like a sea, like an ocean of the medicine. It's not easy. And also we deal with the life. For example, if you go to the sea and you can't swim in 3 minutes without oxygen, will die, right? The same, the airway management, intubation. In 3 minutes, we can lose the patient. If I paralyze the patient by general anesthesia and should intubate the patient and I can't, in 3 minutes, the patient will lose sinus and go, because no respiration. But in surgery, if some mistake happened or complication, just packing under pressure for half hour, no problem. The patient's still alive. Call for help. Then surgeons can come. But in anesthesia, in 3 minutes, if you can't do intubation to the patient, you will lose the patient. So it's more stressful. You need powerful. You need strong minds brave heart, and good knowledge and hand skill to do everything. Okay.
Thank you so much.
You're welcome. Thank you for this nice meeting and appreciate it. You're ambitious about the medicine, and I am a supporter for you and your colleagues.